Do you know how to distinguish between maxillary and mandibular forceps and how to choose the appropriate one for the tooth you plan to extract? The design of the dental forceps has remained constant over the years simply because it is tailored to the shape of the teeth, and as far as I know, teeth haven't changed recently. Each forceps has three parts: handles, hinge and beaks. The handles of the forceps can be straight or curved. The manner in which they are held differs depending on the tooth. Typically, the maxillary forceps are held palm up with beaks pointed upward, and mandibular forceps are held palm down with beaks pointed downward. The hinge transfers the force from the handles to the beaks. There are two main types of forceps according to the different hinge design: American and English style. The former has a horizontal hinge and the handles are held horizontal next to each other, while the latter has a vertical hinge and the handles are held one above the other. The beaks are designed to adapt vestibularly and orally in the cervical area of the tooth. Considering the unique anatomical characteristics of the teeth, distinct beak design tailored to the different tooth groups' morphology is necessary for close adaptation of the beaks to the tooth. It's important to note that the beaks are tailored to adapt to the root surface below the cemento-enamel junction and not to the enamel. The enamel is smooth, whereas the cementum is rough. If the beaks are positioned on the enamel, stable grip will not be achieved and the forceps can slip during luxation. Okay, let's start with the distinction between maxillary and mandibular forceps. The design of all extraction forceps aims to position their beaks parallel to the tooth's long axis and the handles for comfortable luxational movement by the dentist. In all maxillary forceps, the beaks are parallel or close to parallel to the handles. On the other hand, the beaks of the mandibular forceps are perpendicular or close to perpendicular to the handles. I will tell you how I teach my students to make difference between maxillary and mandibular forceps. Listen closely. Imagine that the forceps is a plastic board which has a flat surface and edges. The maxillary forceps are either straight or curved by the plane of the board, or S-shaped, whereas the English-style mandibular forceps is bent by the edge of the board. Now you know how to differentiate maxillary from mandibular forceps. Let's focus on how to choose the right one for the exact group of teeth. Three main characteristics of the forceps will guide you to the correct choice. The first one is the shape of the beaks. One of the beaks always goes vestibularly and the others goes orally, so their shape is up to the tooth. If the cervical area is convex, a concave beak will be needed, and the other way around. The second characteristic is the width of the beaks, which is up to the mesio-distal dimension of the tooth. The bigger the mesio-distal dimension, the wider the beak should be. The third characteristic is the space between the beaks when the forceps is closed. This is up to the vestibulo-oral dimension. So the bigger the vestibulo-oral dimension, the bigger the space between the beaks. Maxillary forceps can be straight or curved, S-shaped. As a general rule, the more posterior the tooth, more curved the forceps should be. Why do we need the curve? To be able to position the beaks parallel to the long axis of the tooth without traumatizing the lower jaw or lip with the handles during luxations. If you find this video valuable, hit the like button, subscribe and comment. You can join our mission by contributing on Patreon. The maxillary central lateral incisor and canine have similar root shape in the cervical area, so the same forceps is used for them. As they are in the most anterior area of the oral cavity, no curve of the forceps is needed. The beaks are spoon-shaped, narrow, and there should be no or little space between them when they are closed. The maxillary premolars are a bit more posterior, so S-shaped forceps is used. The beaks are again concave according to the shape of the roots. They are a bit wider compared to the anterior forceps and there is more space between when they are closed. The maxillary first and second molar have three roots. 2 on the vestibular side and 1 on the palatal side. The vestibular beak should have a spike that goes in between the vestibular roots, and the palatal beak should be spoon-shaped. This requires that the molar forceps come in pairs, left and right. If you're confused which is the left and which is the right one, just remember, spike always goes vestibularly. Additionally, the molar forceps should be even more curved than the premolar forceps, so that the surgeon can reach the posterior aspect of the mouth. The width of the beaks is even greater, and the space between the beaks is even more, because these are the largest teeth in the maxillary arch. A variation in the design is the upper cowhorn forceps. It's particularly useful for severely carious molars because the sharp beaks can reach more apical to the roots. The wisdom teeth are positioned most posteriorly, so the forceps for them has the greatest offset between the beaks and the handles. As the erupted wisdom teeth most oftenly have no bifurcation, the beaks are typically spoon-shaped. The beaks are wide and have a lot of space between them. The forceps for maxillary roots is with great offset, so you can extract roots from the most posterior area of the oral cavity, even though they are quite comfortable for extraction of anterior roots too. The beaks are very thin and sharp, and there is no space between them. The idea is to be able to grasp even the smallest root with them. A smaller version of the premolar forceps is typically used for universal primary teeth forceps. The perpendicular angle between the beaks and the handles in mandibular forceps creates a comfortable horizontal position of the handles for the doctor. The mandibular central and lateral incisors have the same morphology in the cervical area, so the same forceps is used. The forceps is with spoon-shaped beaks, which are narrow, and there is no or little space between the beaks when they are closed. The canine and the premolars have the same cervical root anatomy, so the same forceps is used for their extraction. The beaks are again spoon-shaped, a bit wider compared to the beaks of the anterior teeth, and there is more space between them when they are closed. Mandibular molars have bifurcation. The vestibular and the oral beak have a spike that goes in the cavity between the roots. The beaks are the widest, and the space between them is the biggest because these are the largest teeth in the mandibular arch. Variation forceps for the lower molar is the cowhorn forceps. It has two pointed, heavy beaks that enter into the bifurcation of the lower molar. Erupted mandibular wisdom teeth typically have two roots, like a normal mandibular molar. That is why the forceps for these teeth has beaks which again are spear-shaped, that are wide and have more space between them. So you will ask me, what's the difference between wisdom and molar forceps? The difference is that the wisdom is positioned more posteriorly, and with typical molar forceps it's quite hard to reach the tooth because the cheek is on your way. So the American style of forceps is used with mandibular wisdom teeth. The forceps for mandibular roots have many variations. The basic is that the beaks are very thin and sharp and there is no space between them. The idea is to be able to grasp even the smallest root with them. For primary teeth, a scaled down design of the premolar forceps is being used. Okay, let's recap. How will you distinguish between maxillary and mandibular forceps? What are the three criteria that guide your choice of the right forceps? Why beaks should be positioned on the cementum and not on the enamel? This video provides a concise summary of the knowledge on this topic derived from the referred sources transformed through my clinical experience. If you find it valuable, hit the like button, subscribe, and drop your questions in the comments below. You can join our mission by contributing on Patreon. Only together we can revolutionize dental education.